Okay. Hi. Thank you for that really wonderful presentation, Dr. Spies. I really enjoyed that. I love hearing about diet and exercise and cancer prevention. My favorite part was the picture of your husband, Otto Warburg. I love that. I love that picture. And just a plug for AICR, if you get on their email mailing list for no other reason, they send out fabulous recipes. I mean, really awesome recipes. So if for no other reason, get on the email mailing list just for the recipes. And then the other point I wanted to make before I get started here on my own talk is that with regard to mutation carriers, there is some literature. It's very limited. It's not in Li-Fraumeni, as far as I know, unless other people know of other studies, because this is not an area I keep up with generally. But in BRCA mutation carriers, for example, they have done a few studies in Ashkenazi Jewish women where they showed that physical activity in adolescence can influence cancer risk later in lifetime. And then I think there was maybe 1 or 2 studies on diet in that population as well. So I think that there is definitely room for diet and physical activity with regard to cancer risk in mutation carriers. We also know that diet before cancer diagnosis in the general population has very beneficial effects on prognosis for cancer after cancer diagnosis. So it's definitely worth keeping in mind. And they changed the pointer on me. I don't know how to use this one. So let me see. Make sure I know. Oh, okay, it goes like that. Okay. So I was asked to give this talk today originally because originally it was supposed to be about how to inform LFS patients about how to participate in research and clinical trials. And then when I explained to Jen Perry she was asking me about my job now and what am I doing, and I explained to her, and she said, "Oh, can you talk about some of those things about survivorship?" And I mentioned the term Previvor to her, and she hadn't heard of it before. But has anybody else in the room heard the term? Okay, a good amount on this side. Not so many here, not so many. Some there. Okay, that's fine. So I was just curious. So then it became more than just about participating in research. So hopefully I'll be able to answer some of those questions. So this talk is going to be pretty on a simple level. I'm not going to show a lot of data. This is supposed to be for patients and supposed to answer maybe hopefully some of your more practical questions. So with that, I'm just going to explain a little bit about what it is that I do, because most of the people in the LFS community that know me as the person who runs the metformin trial. So I am doing that, and I was doing that as a postdoc at the National Cancer Institute, where I just finished in this past November. And then I joined George Washington University in DC as faculty this past January. So now my job has sort of evolved. I still continue to do chemo prevention trials. That's still an area that I want to maintain as my research portfolio. But I also do patient care in hereditary cancer syndromes and in cancer survivorship. And they asked me to take on that program when I went to GW, because what's interesting about that program there is that it's not run out of the oncology department. It's run out of the internal medicine department, which you don't really see in very many places. And so as an internist, because I'm not an oncologist, it seemed to be a good fit for me, and they wanted me to kind of take that on. So now I've been expanding from not just in hereditary cancer, but also into cancer survivorship. And it's a nice role for me to be in, because the patients that I see in the hereditary cancer clinics, if they have a diagnosis of cancer, I see them again in cancer survivorship clinic. So it provides a nice continuity of care for both me and for them. So I'm very lucky to have that position. The other thing that's really good about it is that cancer survivors, we don't do such a good job as physicians, whether we're primary care doctors, oncologists, subspecialty care. we don't do a very good job of taking family histories, and so for cancer or any other diseases. And so when I see cancer survivors in the clinic, I pay particular attention, and I have my nurse practitioner pay particular attention to family history, because we do capture patients that way. And so this is another population in which we can capture patients who have hereditary cancer, who have been so occupied with getting through their cancer diagnosis and treatment, and their physicians have been rightly so occupied with getting them through their cancer diagnosis and treatment, that there hasn't been an opportunity to really delve into their risk factors and their family histories. So it's an opportunity to capture patients for hereditary cancer screening. And of course, it's also an opportunity to do research, whether it's primary prevention research via the high-risk population or in the cancer survivorship population, because prevention is very important in that population as well. So Previvorship, I'm going to talk a little bit about this term, and then I'm going to talk about survivorship, and then I'm going to talk about how to get involved in research. So this website is FORCE's website. It's Facing Our Risk of Cancer Empowered, and this is the advocacy group that's for women who have hereditary breast and ovarian cancer with BRCA mutations. It's a very large, very powerful, well-known advocacy group. And this is where the term Previvor actually came from. It was coined in the year 2000 by FORCE. The head of FORCE is Sue Friedman. And it says here, they were featured in Time magazine. I think this was in 2007, where this became like, what does it say? The top buzzword of 2007 was Previvor. And so what is a Previvor? Well, it kind of grew out of a patient who expressed the need to have a better label. And I think there are a lot of patients in this room that can probably identify with that, mutation carriers, because our term in medicine for mutation carriers that don't have cancer is the unaffected carrier. And that just seems grossly inadequate and doesn't seem to really capture the experience of a person who has such an extraordinarily high risk of cancer. I certainly wouldn't think of that person as being unaffected, even if they didn't have cancer. And so that's, I think, what she was expressing. And so she wanted to have a better label. She said, I need a better label. I need something that physicians can identify, that other patients can identify, that I can, get with people who are sharing my experience with. And so that's how the term sort of grew. And so I'll have the technical definition up there, and I'm not going to read it all, but it's basically people who have a hereditary predisposition for cancer but don't have cancer themselves, or they could have some other very high risk predisposition for cancer. It doesn't necessarily have to be genetic, although that's the context in which it's frequently used. And it helps to signify their unique needs and separates them from the general population. So this is the person who, you can read about her on the website, who had said Kathy is her name, that we need a better label. And her reasoning was that she really wanted people to know the term, to understand it, and she wanted it to become as well known as the term cancer survivor. And be able to identify with other people that could identify with her in this situation in which, is very uncomfortable and sometimes pretty scary. And so I just wanted to talk about the program at George Washington University, where I'm currently at in Washington, D.C. So our program there is currently being built up. We have new leadership that came on to our cancer center, Dr. Eduardo Sotomayor, who is from Moffitt, and so he was the one who recruited me there. And so there's a big push at GW to really grow their cancer program, and the changes there have been really exciting. I wasn't there before that, but I'm told that the changes have been really exciting. So in our hereditary cancer program, it's a multidisciplinary cancer clinic. It's a kind of a one-stop shop. Patients come and they're previous to their appointment, they are evaluated by a genetic counselor. They have testing if they have a mutation. Then they see subspecialists according to their needs, and it's scheduled all in one day so they can see if they need fertility counseling, if they need dermatologic screening, if they need to be hooked up with primary care, surgery, oncology, etc. So it's a really nice program, and they've been doing quite well. So I'm going to switch to survivorship. So survivorship is, I'm going to show in a couple of slides, what the cancer care continuum looks like. But basically, the Institute of Medicine defines survivorship as a person who's been diagnosed. You're a cancer survivor from the time of diagnosis, not it doesn't start after your treatment. And so probably a lot of people in this room already know that, so I apologize if I'm already giving you information that you know. But it was interesting that Jen Perry said to me, well, survivorship, we don't have that for LFS patients because, what happens after the diagnosis? What happens after the treatment? What happens for cancer? Where do you go from here? And it never occurred to me that that was something that could be possibly missing from this experience. So for survivors, from the time of cancer diagnosis through the balance of your life, you're a cancer survivor. And the Institute of Medicine identifies 4 signature elements of survivorship care. It is the prevention and detection of new cancers, surveillance, intervention for the treatment effects that you have from your cancer, because there are treatment effects both in the immediate term and in the long term, and then care coordination is really important, and that's what happened with. I actually lost my slide. I don't know where it went, but maybe it comes up a little bit later. So. The Institute of Medicine in 2005 created this report about the cancer survivor, and it was called Lost in Transition. And what's been more and more recognized, even by organizations such as ASCO and NCCN, is that cancer survivors are getting lost in the cracks. After they're finished with their treatment for their cancer, they're somehow, when they're finished with the really, really stringent follow-up with their oncologist and they're going back to their primary care doctors, they're feeling a little bit lost, and some of the really important aspects of their care are falling through the cracks or getting forgotten, and it's very disjointed and fragmented and ultimately probably not good for health outcomes. So this is a big area of research. Currently. So just a few little facts about cancer survivors is that it's a growing population. As our population continues to age, as our population of cancer survivors live longer, there's more and more and more of them. So the cancer control continuum, this is something that you constantly see as if you're in cancer control research, and it starts with prevention and goes along through detection, diagnosis, treatment, and then survivorship is that last stage of the cancer control continuum. And the point of this is to say that there's an opportunity to impact cancer control at each one of these stages. From the time of prevention to the time of survivorship, we can impact cancer control. And survivorship is not just for women. So the reason why I think we have a lot of survivorship programs and a lot of the attention is focused on breast cancer survivors because it tends to be a very common cancer. And I think in general, women are just a very motivated population. We're the ones that take our families to doctors. We drag our husbands or our partners kicking and screaming to doctors. And so we're the ones who want the information, and the men could probably just care less most of the time. But there are survivorship needs for men and for women. And so some of the elements of survivorship care that are really important are cardiovascular needs, bone health, sexual health, coping, fertility, mental health, spirituality. There's a lot of needs that are addressed in proper cancer survivorship care. And so that's what it means to have that. So there's several institutions that have made very strong statements regarding this. The Institute of Medicine, like I had said before, the report that they had published, Cancer Patient to Cancer Survivor Lost in Transition, and that's what sort of set the ball rolling. And from there on, the American College of Surgeons and the commission from which the Commission on Cancer is based, put out a series of guidelines for which they accredit cancer centers. So now cancer centers, in order to maintain their accreditation with the Commission on Cancer, have to fulfill certain aspects of cancer survivorship care for their cancer patients. So every patient that comes through their cancer center with the intention to cure, so a stage 1 to stage 3 diagnosis, they're supposed to abide by these regulations to maintain their accreditation with the Commission on Cancer. And so the key elements in that I'm going to talk about in just a couple of slides is basically to ensure consistency of cancer care for cancer survivors. And it also mandates that cancer survivors all be screened for distress in order to address their psychosocial needs. And the most important thing is that the cancer care plan that the provider is supposed to create with certain elements, which I'm going to talk about, has to be reviewed with the patient by the healthcare professional. It's not enough to print something off of a computer, give it to the patient, and tell them, give this to your primary care doctor, see you next year. You can't do that. You have to sit down and actually go through the care plan with the patient. And it's actually I've been putting together these documents for the last 5 months for patients, and it's not a trivial amount of work. So the American Society of Clinical Oncology has also put out guidelines and recommendations for survivorship care, and they also have a template that clinicians can use. And the NCCN has also put out very detailed guidelines for cancer survivorship care. So that's just the COC. I'll skip past that. There's the report from the Institute of Medicine, and they've listed some recommendations for survivorship care planning, among which these are the elements that are supposed to be included in every survivorship care for every cancer survivor. So your testing that you had, characteristics of your tumor, details about your treatment, supportive services, and also genetic counseling and genetic testing, if necessary, and assessment of familial risk of cancer is an element. And there's also there at the bottom effective chemoprevention strategies. My favorite. So what questions should you ask as a cancer survivor? So this is also on the Institute of Medicine website, so you can just, you can Google it, and I'll also make sure all the links that I have in the presentation are available so that Jen Perry can put them up on the LFSA website. But you want to know what treatments and drugs you've had. And these treatment summaries are really important. When you're going through your diagnosis and treatment, there's so many details and aspects. And even if you're a good note taker, even if you keep all your medical records, it's incredibly mind-numbing to have to go through it all and try to explain it to a provider. So all of this gets put in a treatment summary on the very first page of your survivorship care plan, so that when you go to your PCP or you move towns and you need to go to another doctor, it's all right there, all in front of them. They know exactly what you had, what your diagnosis was, and what you were treated with, and if you had any complications. And it's really a very helpful and important document to have. And then the other things to ask, what kind of follow-up care do you need? How often are you supposed to go back to see your doctor? Are you supposed to go to your oncologist? Are you supposed to go to your primary care doctor? Are you supposed to go to your surgeon? Who's supposed to be doing your surveillance? So there's some accountability in there for which provider is supposed to take care of which aspect of your care. What do you do to maintain your health and well-being? So these are the questions that you can ask. Let me see. Health insurance is another thing that comes up. We have social workers that meet with patients to try to make sure that they get their questions answered in that regard. And the most important that I've highlighted there in red, which I've already mentioned, who's accountable for which part of your care? These are things that get overlooked. It sounds simple, but during the course of treatment and diagnosis and treatment, these are things that get frequently overlooked. And do these plans have an impact on health outcomes? So this is an area of really active research, and one in which people who are invested in this type of research and type of care are fervorishly trying to work on and produce some kind of hard data that survivorship care planning makes a difference in terms of prognosis and adverse health outcomes. And so there's a little bit of research, and the NCI's Division of Cancer Control and Population Sciences is heavily invested in trying to fund research to actually look at this question. And so there was a recent study that just came out that states that patients who go to survivorship clinics report, having a better experience, getting their questions answered, but perhaps in a more concrete way, they adhere to recommendations for their health in terms of screening and surveillance a little bit better. So that's encouraging. This is what the NCCN guidelines for survivorship looks like. It's a packet. It's about, yay thick, and I have to keep it on my desk and constantly look through it. And so what they address in those guidelines are pretty much every facet of survivorship care for the cancer patient. Cardiac toxicity is a big one. There's a new and evolving field now called cardio-oncology, where there are cardiologists that are focusing on the cancer patient, looking at long-term effects of various types of cancer therapies on the heart. Because as I said, patients are living longer and longer, and now we're starting to see these toxicities 10, 15, 20 years out from cancer therapies. Anxiety, depression, cognitive function, sexual function, immunizations. It's amazing you overlook immunizations when you don't think about them with the cancer patient, and it's something that I've had to learn about in my last 5 months. I've been taking a crash course in this. When is it time, especially if you've had immunosuppressive therapy, there are certain immunizations that you probably should get again, and you need to make sure that you have keep up with those. So those are all really important things. This is the American Cancer Society website, so there's information there available if you want to start learning a little bit about things that you need to pay attention to as a cancer survivor. And this is just a nice model. I like this picture that shows what all the moving pieces are in regard to survivorship care. Your family is important. There's the immediate stage, there's your acute stage, there's the stage that's permanent, because if your life has been altered in a very significant and permanent way, there are things that you need to be paying attention to. So it's a nice model to kind of show how family is also really important, and then what are some of the other really central issues to pay attention to. But the biggest message is that cancer survivors require very good coordinated care. Our current system of fragmented care just really doesn't work, and it's you have to maintain, in fact, with the guidelines for survivorship care, oncologists and primary care physicians are supposed to have steady communication. There's supposed to be communication between the oncologist and the primary care physician. That plan should be delivered to your primary care physician by your oncologist so that your PCP knows what it is that they need to do to take care of you. So in our clinic at George Washington University, we create a personalized survivorship care plan for every one of our survivorship patients, or our cancer survivor patients. So far, I've seen women and men. We see all cancers, but we would see all cancers, but what I have seen so far in our clinic is breast and colon cancer in women. And then we have a kind of unique population in DC. So of the men, I've seen some testicular cancer survivors, lymphoma, and then there's now a focus on the LGBTQ community, as well as we have a big population of HIV patients. And so GW is known for their HIV work as well as their policy work, which makes sense since they're in DC. And so I've actually had to see these patients who have either high risk for HIV because they have partners who have HIV, or have HIV themselves, or are part of the LGBTQ community, and they have unique cancer needs as well. We also have a clinic called TAC, and this is a clinic that we work in collaboration with the Children's Hospital in DC, and these are adult survivors of childhood cancer patients, and they come to that clinic once a year, and there's providers from Children's that come over to GW, and GW providers, and they meet in a multidisciplinary team and see those patients. So it's a really nice clinic. The other thing we've worked hard at doing is making sure that we have providers and subspecialty people to make sure that we can address appropriate symptom management in our patients, because symptom management becomes a huge thing for patients after treatment. They need help with managing things like neuropathy, physical therapy, occupational therapy. Cardiovascular health is a big thing that we're going to be developing more initiatives in cardio-oncology. Complementary medicine, we've worked hard. We have a Center for Integrative Medicine at GW, who's run by a physician, and so we've been working with them to try and make sure that some of those modalities, like acupuncture, massage, things like that, are available to our patients. Lymphedema management, bone health, vaccinations. So these are just some of the things, and of course, screening for hereditary cancer. I just wanted, I'm just going to skip this slide. Well, I'll just talk about it a little bit. There's the concept of late and long-term effects, which is very important in cancer survivorship. So late effects are things that are unrecognized toxicities that your body essentially takes a hit but doesn't manifest years and years later, and cardiotoxicity would be an example of that, whereas the long-term effects may be something that you start to experience during your treatment, but then continues after treatment. So neuropathy or lymphedema might be examples of that. So it's hard to find literature, for cancer survivors in Li-Fraumeni syndrome. There's not a lot of that. I was looking for something that I could present, and most of it focuses a lot on, there's some things on coping with it. A lot of it focuses around genetic testing and counseling, which is great. I mean, we need that kind of research. And here's a paper that was recently published by Ms. June Peters from Dr. Sharon Savage's group, which was, I think, a really nice paper, just kind of making the point that, as cancer survivors, Li-Fraumeni patients, you're not just your mutation, you're not just your cancer. There's a whole aspect to your lives that needs to be recognized and needs to be addressed, and spirituality and emotional well-being is, of course, one of them. At GW, we also have an Institute for Spiritual Health that's associated with our palliative care doctors, and it's called GWISH. I always thought that was kind of a really nice name. And so they're very interested in this aspect of care. So I'm going to switch to participating in clinical research. And why should LFS patients participate in clinical trials? So we've heard a lot of research in the last couple of days, and so I think that the people who spoke here, particularly some of our patient advocates, can explain why it's so important much better than I can. So I wrote down some quotes over the last couple of days, and some of it's paraphrased, so pardon me if I didn't get it exactly right, but I think I got the sentiment. Rare cancer syndromes may hold the key to interventions and progress in cancer, Dr. Rob Lufkin. We are the building blocks to a future without LFS, Jen Perry. We have not made enough progress. Children are dying every day, Oliver Weiss. And Amanda for that amazing talk that she gave, the quintessential LFS survivor. And I think mostly, to find the key to prevention and to cures. I mean, I think that that's the bottom line for participating in research. As you know, participating in research is largely an altruistic endeavor. If you're going to participate in research, you have to be comfortable with the fact that that research may not immediately impact you, but maybe on your children or future generations. And so you know that going into it, and I can only hope that it brings you some degree of comfort, but it is extremely important. So participating in clinical trials, the NCCN recommends participation in clinical trials. It's right there on all their, cancer care guidelines. And I think it's good for a number of reasons. When you participate in a clinical trial, you're being monitored pretty closely by the physicians that you're in the trial with. And I think it's ultimately probably better for your health outcomes. Now, I haven't looked at any formal studies for this, but I think that that's sort of the rationale behind participating in clinical trials is, number one, you get the latest in the treatments, the most cutting edge type things. And then you're also being watched very closely. There is a relationship between how many times a year a patient sees a physician and their ultimate health. And so I think that's probably one of the benefits, aside from whether or not the therapy that you're getting really works or not. And then, of course, contributing to the fund of knowledge and advancing therapy and cures. And so how do you find clinical trials to participate in? There's not any... my one go-to source is clinicaltrials.gov, and I'm going to show that website up here. But your healthcare professional, your genetic counselor, advocacy groups, the American Cancer Society. So I'm going to show a number of websites. Also, the Affordable Care Act actually is written in a way so that cancer patients, insurance companies are mandated to cover routine costs of participating in a clinical trial. So like, blood work and things like that. Not the investigational agent, which shouldn't cost you anything, but anything that's involved with your routine care while you're on the clinical trial should be covered by your insurance. This is the American Cancer Society Clinical Trials Matching Service. So they have a service that's there available for patients to use to call and inquire about what clinical trials may be useful for them or match their needs. The Wall Street Journal had a great article about getting involved in clinical trials, how to do so, a number of good websites. And again, I'll make sure these links are available on the slide presentation for people to use. This is another website, the Center for Information and Study on Clinical Research Participation. And then this is the one that I use, clinicaltrials.gov. And so I'm just going to show a few screenshots, and then this is going to be the end of my presentation about how to use this website. So the search for studies there, I put in LFS and metformin, and if you type that in and hit search, you'll come up with the one trial right now. But then there's other ways to do the searches. I had put in Li-Fraumeni and came up with 9 studies found for Li-Fraumeni. And then you can go to the more, if you see up here, I don't know how to use the pointer thing. I'm just not going to bother. But it says modify this search under there. And so you can go in and fill in some more fields. So I put in Li-Fraumeni and I put glioma under conditions. And you can play around with this. And then I went down further on that page and checked off child for the age group that I wanted to look in specifically, and came back with 111 studies for glioma patients. Actually, this was not LFS. It was glioma studies in children. And so here's some more helpful links for finding clinical trials. And again, I'll make sure that these are all available on the slide presentation for you to look up and pay attention to and play around with. And that's it. Thanks.